Okay, we have one more panel, so we're moving this conversation to implementation. So Michael Luella, who many of you know, for the past 13 years, Michael has worked for the University of Washington's AIDS Clinical Trials Unit as an educator and recruiter. And he also started working for Defeat HIV, the cure research group at Fred Hutch that is working on a way to mimic Timothy Brown's cure. Michael.
Thank you all for coming. I'm going to try to make it really brief because I've been told we are running out of time. I want you all to help these people who are going to be sharing some things that I've asked them to share with you, and it's what you can do. What do you want to hear from them? And you have to kind of generate that energy in yourself, and you kind of beam it to them. They have stuff in there for you. They have stuff inside that you want to hear from them. And if you give them that sort of focus, and if you really say, like, come on, what is it I need to know from you? And you have that thought as they're talking, you will be surprised at what they might say, and they might be surprised at what comes out of their mouths that they didn't plan. So that's what I'm hoping for. We're talking about implementation. We're talking about implementation. And what I asked them to do is in 5 minutes, I wanted them to discuss a success they had, a challenge that they have, and I wanted them to end with a dream, because one of the things that I think we do not talk nearly enough about are the dreams that we have about what we would do if we had no concerns about funding or money. What would you do if you had all the money in the world to do what you think you need to do to stop HIV among MSM? That's what I asked them to share with us. I asked them to end on a dream. We're going to give them each 5 minutes to share all of this with us. And then I'm going to give them 2 minutes each to comment on each other's presentation, so to speak. And then we're going to open it up to y'all. Okay? So we're going to start with our first victim, M. David Bayless. And David works as a disease intervention specialist in the Snohomish Health District. In 1999, David started volunteering with a queer youth group in Everett, which at that time was part of an HIV prevention program. He turned the volunteer gig into a new career that has thus far lasted 14 years. He lives in Seattle, but his work just 26 miles to the north makes him keenly aware of the different approaches needed for HIV prevention in more rural communities. So if you would please, David, you got 5 minutes to tell us all you got.
Okay, not only did I have to figure out what to say in 5 minutes, now I'm responsible for their beams. So beam all you want, I may not be receptive. It's a challenge for me to kind of explain a little bit of what we do up in the north, and if you're from a rural county, you kind of understand this, because it really is 26 miles away, but it is night and day from King County. So we work in a predominantly rural area where there's only one gay bar, and it is 50%, I think, gay, and every second Saturday it's a lot of lesbians. And it's a challenge, if I start with challenges, to try and identify MSM in our community because there's no congregated place. The success that we've had is in our public health clinic, the staff have a very good reputation for being culturally competent with MSM, with non-gay identified MSM, and the few people of color that we have in Snohomish County that will come to us, to be honest, I think we have a very good reputation. We've also done some great work with establishing relationships with the owners of the gay bar, for example. You know, there's a adult video bookstore, for example, that we have a good relationship with that we're building on, but they're still unwilling to allow us to do testing, for example. So we've had to work with that. It's very different, I think, up there simply because of that. We talk about a bedroom community a lot. And when I'm looking at numbers in terms of epi, you know, possibly 45 to 50 new cases a year, and if 20% additionally don't know their status, we're putting a lot of time and effort really to identify, 70 new cases around the I-5 corridor. And if I look at what we have in Snohomish County, another challenge, there's no out-identified provider. The social structure for a lot of people really is to drive down to Seattle for both the social piece, the bar piece, the sex piece, and also the provider piece. So it is a struggle. You know, when I have a community meeting, for example, I'm going to see a lot of the people that I see all of the time, some of whom are HIV positive and we have great relationships, some of whom aren't really at risk. But when I go to the bar, or my coworkers go to the bar, I see all of these young MSM walk through the door, and I don't know who they are, and I've never seen them before. And that's a challenge for me. When I think of a high-level challenge, which probably isn't the most appropriate thing to say as somebody who works for public health, but I am not 100% convinced that the value public health has in lowering the rates of new infection is the same value among MSM. If we are spending so much time and effort trying to reduce the rate of new infections, and that's our value, and we're trying to think of all of these tools to push that onto the community, I don't think we're going to be successful. I don't know that we have a really good sense of what is the true value of MSM communities. And it really is plural. There's no one community, even up in the north. So I think that's a huge challenge. I'm also not Pollyanna and I'm not a Debbie Downer, but I love that we have a goal of 0% transmission, but brace yourself, Effie. We're not going to get there. I really don't believe that we're going to get there. We're talking about social behavior that feels really good, and we're trying to tell people to change that, but we're not giving them the right motivation to change. I work with a queer youth group, and I look at my young MSM, and when you hear about they're not motivated by the same fear that my generation or older had, I think that's true, but they're also motivated by the reality of the medical interventions. And so how can I look at them and say, you need to do this, you need to be concerned, when maybe they have a person who's HIV positive that's very good at their medications, they're doing really well, so they don't see that motivation. I think we need to be better at figuring out what motivation works for the different communities. So in a community-less rural area, if I could say that, like we don't even have a Pride anymore. We all come down to Seattle Pride, right? Mm-hmm. There used to be. That's a big challenge. So if I had a dream where money wasn't an issue, I would actually just expand universal testing, or rather include universal testing, right? I would go out to the places where they're having sex. I would have a higher presence on the internet. And I would hire at least 10 gay and lesbian identified providers and bring them to Everett and set them up, give them a house, give them a car, and have them influence our community in a way that would be positively impactful so that the clients aren't coming to them.
Beautiful. Thank you very much. Well, Karen Hartfield has worked in HIV prevention since the beginning of the epidemic. She has planned, implemented, managed, and evaluated MSM prevention programs at Public Health, Seattle and King County, and is on faculty in health services at UW's School of Public Health. Please welcome Karen. You got 5 minutes.
Thank you. Am I supposed to do something with this, or can you hear me?
We can hear you.
Good. I so wish I'd worn a hat, though, really. So really quickly, I really like the way you organize the panel, making us think about successes. And a lot of the work that I do is working with our community-based organizations, which in Seattle King, we're fortunate to have a lot of community agencies that work on HIV prevention with us. And one of our successes, I think, has been moving the biomedical model out into the community. So we have a couple of very strong CBOs that provide HIV counseling and testing. And then most recently, we've actually been able to expand, sort of diffuse the community-based testing out into almost all of our contracted CBOs, such as Lifelong and Seattle Counseling Service. And I think what we've learned from that is that there are some clients who really feel more comfortable going to community-based organizations than to public health or even to Gay City. In terms of measures of success, which is one of the things you've asked for, we have identified a few cases that way. It's been challenging logistically to figure out how to provide testing in community-based settings. The way we're doing it is by depending on Gay City to send their own testers to our CBOs, which I actually think is a good model because it's very difficult for community-based agencies to get a testing infrastructure up and running when they're not going to have that many clients. So that's a success. And a second success, because how could you limit to one?
Exactly.
In such a successful area, has been adding asymptomatic STI testing, again, out in the community. So while that's available at our STD clinic, historically, there are some people who don't want to go to the STD clinic, or they don't have symptoms, so they don't see why they should. So that's increased access to MSM. It's helped us identify more gonorrhea and chlamydia out in the community, and syphilis. And as a measure of success, in order to continue the funding for that project, we set a threshold of 5% asymptomatic positives, and we've been able to reach that at Gay City Health Project. The challenge is, I think, continuing in that mode of the biomedical testing, treatment, test and treat model. It's been a challenge to identify clear roles for our community-based partners who are more used to doing primary prevention, such as counseling, one-on-one interventions, the so-called DEBIs, to identify clear roles for them that help with identifying cases and linking to care. So how can a CBO get a clinical infrastructure up and running, including billing, now with the Affordable Care Act, when they're running on shoestring budgets? And a second challenge, I think, has been, have we already saturated the market in terms of gay men and testing? We're trying to shrink that inter-test interval, but we're making really incremental progress. The other challenge is that we know there's a need for primary prevention, but how do we continue providing the services that keep negative in an era of outcomes-driven prevention? That's been a big challenge. And finally, my two dreams, free mental health counseling and substance use treatment for all. I think those are two of the biggest drivers of continued risk behavior. And my second dream is dreaming that the Affordable Care Act helps people see the value of preventive care, not just providing it and asking them to sign up for the service, but helping people see why it's important. Done.
Wow. Wow. We're going to have lunch in no time. You did all of that in 3 minutes.
I did.
That's beautiful.
Can I say some more now?
Very efficient, very efficient. I love it. Next, I would like to introduce to you all Ronnie Myers. And Ronnie is the program coordinator of the STD, HIV, hepatitis C, and Adolescent Health Program for Multnomah County. She is a program coordinator with the Multnomah County Health Department. Oh, I'm going to have to read that sentence again. I'm going to stop that one.
No.
She has over 25 years of experience working primarily in community-based HIV prevention programs and community coalitions.
Thank you very much. All right, so I'm going to talk a little bit about a couple of the successes that are happening in Multnomah County. And the thing that I'm going to focus on is so we've done a little bit of talking before we came, what should we talk about, et cetera. So what we really wanted to focus on, which I think is a really strength for us in Multnomah County, is that we have really good relationships, really strong, good relationships between state health departments, local health department, and our community-based organizations. We have similar goals, we have really good relationships, and we do a lot of work together in collaboration with coalitions. So I know it's happening in a lot of different areas. We don't have a lot of the research, resources, et cetera, that are in this Seattle-King County area, but we try to do a good job even without that. Mm-hmm. So I'm going to talk, also I have two successes, even though I was asked to only give one. So one is the work that Multnomah County Health Department has done with Cascade AIDS Project, otherwise known as CAP, in really looking at integrating STI screening, treatment, et cetera, into HIV testing and having it available both. So I think a similar thing what I see is happening with Gay City, both at the STD clinic at the health department, but also integrating it into Pivot, which is CAP's, I suppose, Gay City. So really a space that's by and for men who love men with a focus on sexual health and HIV. So we have been doing that by having the health department clinicians, disease intervention specialists going to Pivot a couple of times a week, offering those combined services. It's a completely collaborative effort between the two organizations. CAP is also doing HIV testing at the same time. In addition to that, we are also training and have trained CAP staff to do phlebotomy so that they can start to integrate syphilis testing and hepatitis C testing into their other HIV testing services that they're providing. And then there also are plans to start to train some of CAP staff in some of the self-collected other STI screening so that they also can start integrating gonorrhea and chlamydia screening into some of that. So that is something that has been a real success. It's ongoing. Seen a lot of men accessing those services and really looking at how can we increase that, the amount of really those combined services for STI and HIV screening. So that is a success. The other success I want to talk about is something that we're doing to really try to address stigma and homophobia within the African American community. So together with CAP and other organizations, we work very close. We're active members of a coalition called the African American AIDS Awareness Action Alliance, or A6. A6 is working with the Albino Ministerial Alliance, which is a coalition of African American churches. And what we've done is we've developed a pilot project called the African American House of Faith Community Health Worker Project. So it started in January, just in January, so we're moving into our half-year mark. So we currently have 6 houses of faith involved in the pilot project. We have about 24 people, combined youth and adult, who are working as community health workers for the project, who we are training to be community health workers both within their houses of faith, but also within the community at large, their friends, their family, being at community events. They're planning on being in the Rose Festival Parade, and being at the Juneteenth celebration, so really trying to get that word out there. So there is a real emphasis on reducing stigma, increasing education and information that's out there, hopefully increasing people who are accessing testing, treatment, et cetera, and really trying to deal with homophobia, sex phobia, transphobia, et cetera. So we've had a lot of really good, rich conversations within the community health worker group, and that group meets twice a month to get additional training and kind of work on activities. So that is also a real success that we're excited about. So I'm trying to talk really fast.
Feel the beams.
Feel the beam. So when I thought about challenges, actually one of the challenges that we have had most recently is another collaborative project that we're working on with CAP, and we are looking at trying to adapt social network strategy so that we use more online social media techniques as a way to try to minimize the amount of time that we have that we spend on recruitment, orientation, training, support for the recruiters for the project, but still support them enough so that, we get a lot of people who are not regular testers or maybe who have never tested before to come in and test. So we have developed YouTube videos, websites, et cetera. We're recruiting a lot of recruiters, and those folks are having a really hard time getting people to come in to test until just recently. So we have had a success. So, the whole texting, emailing, going through their hookup sites has really not really taken off yet. And so that has been a real challenge. We've been working with those recruiters, surveying them, what's working, what's not working, what can we do differently. And we just have gotten a recruiter in who is awesome, who is really out there recruiting people out of Grindr, Craigslist, people he doesn't even hook up with, but he's really recruiting them and they're coming in to test. So we are now going to be working with him to look at, we just said, hey, do you want to do some YouTube videos so you could train the other recruiters about what are your strategies, how are you doing it, et cetera. So he's very excited about that. So it has been really a challenge, but we're trying to work through it, and we have a exciting success that's coming out of that too. So a dream would be that we have consistent resources, that we could stay focused on the work at hand and not have to always be kind of swinging back and forth based on whatever national emphasis is to do this, do that, know that. Oh, we really meant this. You have money, you don't have money. So it would be nice to have some stability. So we could really focus on things, have it be community-based, really look at the strengths within the community, focus on that work. So that definitely would be a dream. The other dream, and again, this is a shared dream, I don't want to say it's just mine from talking with other folks from our county, is that really looking at ways to address HIV as a social justice issue and looking at how we can combine with other efforts, organizations that are looking at social justice, looking at social determinants of health, and look at how HIV can collaborate, work with them, support them, because that is really a way that we believe is going to affect HIV and other issues. So really working on homophobia, transphobia, sexphobia, racism, body image has been a big place, classism. So some of the things that we did see about, what are some of those core determinants of health that affect what's happening with HIV among, I think we saw for MSM of color, and just infection rates, et cetera, getting into healthcare, getting treatment. And to really be able to integrate that into schools, into the healthcare system, hopefully Affordable Care Act, really being able to look at what are we doing around making folks culturally competent, addressing that as really the social justice. So that's it. Thank you.
Beautiful. Thank you. Next on our lovely panel, we have Daniel Schollaert.
Good job.
And Daniel, thank you. I got it. I practiced it.
Yep.
He is an HIV prevention specialist with Cascade AIDS Project. And Daniel has received his BS in psychology from the University of Washington in 2003. And he has completed his master's in public health at Portland State University in 2006. He is personally and professionally committed to the LGBTQ health equity and has spent the last 5 years coordinating Cascade AIDS Project's HIV STD testing clinic in Vancouver, Washington. Daniel.
Yeah, so a lot of people have already addressed some of the things I was going to talk about, but I think especially what David was speaking about, Vancouver is a really interesting place. We're really close to Portland, so some of our unique challenges in doing recruitment for STD and HIV testing clinic are really around the idea that we're a satellite community or a bedroom community of Portland. Guys play, they date, they hook up, they actually test a lot of times at our clinic in Portland. So we end up having to focus on parts of the community that aren't necessarily easily identifiable. Two groups that we really work with a lot in Vancouver specifically are around the young MSM community. So similar to David, I'm working on an effort to open a queer youth resource center in Vancouver. There's already some queer youth services, but really people that don't have access to transportation and experience social isolation as a result of not being 21, not being able to go out and engage in the bar culture, which is a lot of what the openly gay spaces are in Portland. Are really an issue there, and also non-gay identified MSM. So we have a lot of folks in the community that we recruit from Craigslist and people that don't really get HIV prevention messages in other places, like that we would normally target in our outreach efforts in Portland. So whenever I was thinking about what to talk about today, I really came back to this conversation or this idea of like, what is community? And I heard a lot of people talk about it in the presentations this morning as well, really talking about the difference between community engagement, and we talk a lot about community mobilization. I'm also in the HIV prevention planning group with 3 other folks that are up here for Washington State, and we talk about this word a lot, about how do we mobilize the community. And the more that I think about it, the more I think about, is it our job as public health to mobilize community, or do communities mobilize themselves or organize in the face of public health threats? And I think if we look at the history of HIV, especially the first 15 years of the epidemic, there's a lot of community organizing that happened, and it happened by the community and from the community as a really community-based effort. And the place where we find ourselves now, I think a lot of people have called it a question, like David said earlier, what do people have the same values in the communities that we work with that we have? If we want to see an overall reduction in new incidents in Washington State or in Oregon State, what about the guys that we work with? Are they getting tested out of concerns for their own personal health, for community health? And I don't think we always do a really good job in public health about communicating what our goals are and getting that community buy-in. And I think talking about community-based participatory action research this morning, that's a lot of stuff that I hear a lot of people talking about, and I'd like to see more of happen in Portland. But like Ronnie mentioned, we have similar epidemic of what's happening in Oregon and in Southwest Washington, but we don't necessarily have the same research resources to partner with local universities. We've done some of that in the past. A couple challenges and things that I have been thinking about as well, or one of them is, for me, working in Vancouver, the river, which I gotta say, having everybody here today is really amazing to have folks from every level of HIV prevention planning and implementation on both sides of the river in one place to talk about it, because I end up having a conversation with folks that live in Washington or that work in Washington, and it's sometimes there's levels where we don't really communicate. Another thing, going back to the issue about community that we've done at CAP in the past, we implemented Community Promise, which is a CDC intervention in 2007, and it's something that we've talked a lot about, and it's a big part of our training process at Cascade AIDS Project, because the community identification portion of that intervention was one of the biggest places where we've actually got to hear the voices of local guys in the community. And because of that, it's something that we have new hires read so that they know more about the cultural norms and the actual practices of what's happening in the community. But it's also something that is an intervention I think we had limited success with for a variety of reasons. One of them Eric mentioned, not knowing a denominator for how many guys there are. It makes it kind of difficult to evaluate community level interventions. But ultimately, a lot of the upstream things that we want to do in our public health work are really they're really things that we need to have those community level and systems level interventions in place to do. So what I'd like to challenge folks to do this afternoon when we talk about what to do with future interventions and the work that we do, to really think about is our community on the same page as us? Is it our job to mobilize community? How are we going to implement community level interventions and do things that are outside of the test and treat model, which seems to be the way the pendulum's swinging right now, as Ronnie mentioned. And I'm really looking forward to hearing other people's ideas. But my dream is to kind of see HIV become less issue-based and see us have a conversation with the community about how we're going to bring this community activism back together with the struggle to end this epidemic.
All right. Thank you, Daniel. Last, I'd like to introduce each of you to Justin Taylor. Justin is the Empowerment Olympia Program Director for Pierce County AIDS Foundation. He's received his Bachelor of Fine Arts with a focus on media production and business leadership from the Evergreen State College. He's a current member of the State HIV Prevention Planning Group, a Washington State certified HIV tester, and he has been running group-level interventions for young gay and bi men for the past 4 years.
Yeah, thank you. I think everyone said everything that I was going to say. Now, hopefully I can share something that is useful and doesn't have too much overlap with other people. My background's a little bit different, and it all started with an HIV test I had that kind of inspired me. But my background is in media production, a little bit in advertising, and also I was a sales manager for several years. And so when I first started working with young gay men and doing HIV testing, 4.5 years ago now, I had a different hat on at the time. You know, it wasn't about offering services, it was about selling services. And so there was a different lens I was viewing things through. And one thing I took from sales management was looking at the experience, selling the experience, and understanding people, buying habits. And so that's really been helpful in some of the successes. But to give you some context of some challenges we've been facing as a community down in Olympia. So I run the empowerment model currently, which is an empirically tested model that works doing outreach with young and gay bisexual men under the age of 29, looking at creating change behaviors, condom usage consistently, frequency in testing, et cetera. And we also reach to a lot of rural counties. Being in the capital, there's a lot of areas where people will drive 20, 30 minutes, places like Centralia, to come and get testing services. And the same thing too with the bars. You know, we're always kind of competing, but I look at it as a model for why people are actually going out and how can I tap into that trend. You know, how is a beer company selling beer inside of a bar? That's the same way we should be looking at how we're selling condoms and how we're selling testing. And so that's just kind of the lens, and hopefully that's helpful as I kind of dive a little deeper into this. But some of the challenges we're facing, I mean, it's always funding, right? There's not enough money to do what we want to do. Mm-hmm. And so the way I have viewed it is access and visibility, right? And if you imagine the x-axis as accessibility, and on a y-axis of a graph you have visibility, As that increases, your cost increases. And so you can't always do both to the same standard that you want to do them. And what I found is that we have accessibility when I came in 4.5 years ago, but we didn't have the visibility. And the problem that came up was, why are people driving to Seattle to Gay City getting tested when 2 blocks down the road we had the access? So it was a very curious thing for me, and so that kind of led me to start emulating successes of what, how people sell services, and not only just service providers. It's about understanding people and that migration too. I mean, people from Olympia will go up to Seattle and they will hook up, and vice versa. And so unifying some of the messaging that I've been seeing elsewhere and getting the volunteers, because we're only 1 full-time staff, and so a lot of this is volunteer run. You know, we've had to innovate. You know, our budget is, you know, $60,000 a year, and we're doing full-time HIV testing on a consistent basis every single week, along with all the other programs happening. And how we could actually sell that experience and tap into trends and not try and use our money to set new trends. And not just with service providers, but with other businesses, and looking at where innovation and where trends are going. And one thing I've seen as a challenge in this, well, I come from a nonprofit background, but also with Department of Health, is that we're always 3 or 4 years behind these trends. You know, we're trying to get on Facebook right now. We're trying to tweet right now. You know, but this is something that's been set up for the last 3 or 4 years. I mean, I think newscasters beat us to it 2 years ago, and we're just now tweeting. So looking at all the different things that play into trends and to kind of the market, if you will. Something that jumped out at me, which made me feel a little bit old, and I'm not that old, is the younger generation doesn't even use email anymore. They'll Facebook the Empowerment Facebook page and say, hey, can I come in for a test? You know, and I'm always concerned about privacy, and I'm just so surprised that people on a weekly basis will just write a Facebook message about, you know, coming in for a confidential HIV test. Successes we've had have been trying to be at the forefront of social media, reaching out to hookup sites, Grindr, Adam for Adam, things like that. But a few key questions I asked myself when I first started is, how can we look at access? How can we look at what works already, what other people are doing, so we don't have to reinvent the wheel, and not just strictly look at innovation? And how can we look at visibility? And how can we create our tentpole for our brand, and how can we create that tentpole of all the different services that we have and be able to market that with a strong identity? Sorry, I lost my train of thought here. So some of the successes we've had is really tapping into that brand and using it as a platform to let the young men that utilize the program innovate, but there's a structure there and there's a support infrastructure for them to actually do that innovation. You know, and I would stress the fact that you can find inspiration, which inevitably sometimes leads to innovation, when you're looking at ways you can emulate success from others, and not just us in this room and not just service providers. Example being, I went out to a restaurant, it was my birthday, and when I left, it was fantastic food, but when I left, they handed me a card, and I said, what's this? And they said, well, don't open it, you come back, there could be a coupon in there could be a free meal, there could be, you know, $100, $200 or whatever, I don't even know what the prize was. But I've held on to it, and I'm gonna go back. And I sat there looking, and I said, gosh, they do this really well. How come we aren't looking at how other businesses and how other service sellers are actually providing services? And I think that's been a key success for us on such a limited budget. And then, I actually wasn't paying attention to my time, but a dream I have is always a cure. But when we're looking at technology, when we're looking at how we can unify all the service providers offering HIV testing, our condom distribution programs, in my mind, there's no reason why my volunteers down in Olympia and me are creating marketing materials that aren't overlapping with what Seattle's doing, aren't overlapping with what other counties are doing in their areas, because we're multiplying our labor that we don't really have the money to spend in the first place. There should be a unified effort. I think the Find Your Frequency campaign was a great example. We saw a spike in our testing in a matter of weeks of that campaign, because you have a multi-point impact of how you do advertising. The more reinforcement you have over similar messaging, the more likely people are to come through your doors. And so with that, if people are clubbing in Seattle and they live in Olympia, and they see the same campaign in Olympia, they go to the site and they see all the different areas that they get tested. Not only do you have accessibility, but now you have consistent visibility up and down the I-5 corridor. So I would like to see, just one of my dreams is kind of unifying that effort. And actually, I'll end early too.
Hey. Well, thank you. Now that was beautiful. Thank you each. I really liked hearing your dreams because I think that's where some of our power is. But before I open it up for questions, I promised you each a chance to comment on what you've heard from the others. So I was just going to go down and start with David and have us go down. And you can comment or you can ask a question if you want, but I promised you that first, so I'd like to do that still.
I'd actually...
You don't have to.
No, I'm going to defer in case you guys have more questions.
Beautiful.
And because I went last, I think I want to do the same thing. I kind of had a chance to comment a little bit on the items.
Okay, great. Karen?
Yeah, I actually do have a thought. I heard a lot of you talking about being sort of like bedroom communities and that people are going to Seattle or maybe Tacoma for services. And so my question really is, what services do you think need to be in place in a bedroom community?
Well, I'll speak to we lost funding for our public STD clinic. And the thought was that perhaps other community providers would take that mantle up. And what we've seen is that that isn't the case. And part of that, I think, is cultural competency. When we saw numbers earlier about, when I'm talking to my MSM clients, I'm like, are you going to your doctor and telling them that you're having sex with other men? And for a lot of my people, it's no, because I grew up in Snohomish and my parents also know my doctor. I'm not going to tell my doctor, regardless of what they believe of confidentiality. So that's a real barrier for some people. And it's easier, I think of that for Snohomish, but I see people from San Juan Islands coming to me because that's removed from San Juan. So I know in a smaller prevalence community, it's harder to do that, but I would like to see increased services that we could offer to our population. But funding, I don't think is going to allow that.
Yeah, in response to that, I think I've seen a lot of changes happen in the work that we do in Vancouver over time, and we started by having just HIV testing. That's the way it's been for a long time. It was run by the county, and we've really seen an increase in the number of folks that are accessing services by adding STD testing, because we have that available through our partnership with Clark County Public Health. And I think that's been, in a way, the folks that I chose to talk about when I was speaking earlier about young MSM and non-gay identified MSM are really oftentimes the people that are the highest risk. So we have a lot of people that come in and get tested that are having oral sex that don't really have a lot of risk for HIV. And then we get people that come in that just didn't get any public health messages, or they're not part of a community, or they were feeling socially isolated and they ended up in a situation where someone took advantage of them and said, oh, well, this is how we're going to do things. And those are the folks that I reach every week at the clinic that I feel like we disproportionately see sometimes in those settings. And oftentimes those are people that they have access to transportation issues that definitely prohibit them from accessing services in Portland. So I think it's important to focus on both areas.
Thank you.
Ronnie?
I will pass.
All right.
Allow for more.
Daniel?
I don't have any other questions.
All right. Well, thank you all very much. I really appreciate this. I wanted to open it up quickly to any of you. You've heard a lot. I heard a lot. I have a lot of questions, but I think I'm going to hold on to mine because I can get in touch with these people because I got their emails. But do you have anything that you would like to ask or comment on what you heard? Or is it all ready for lunch? Is that what you're doing? Well, then how about if we... Go ahead. Oh, go ahead. Hurry up.
This question is probably more so for the community-based providers. And I wonder if there are any ways, or anybody can answer this, that you try to instill or encourage a sense of community among the gay and bisexual men that you serve or you work with. If there are ways that you try to encourage a sense that we are sort of in this together, looking out for each other, that taking care of our health is important for us personally, but also at a community level. I wonder if that is, to what extent is that possible, and to what extent is it sort of happening in your work?
Yeah, I can respond to that. In our clinic, we have myself as a full-time staff, and we have one other person that tests part-time, and we have some people that are like backup testers. But all of our reception and a lot of our help with testing, like paperwork processing for STI testing, is done by volunteers. And there's been a lot of circumstances where people come in and they're in this moment where they're really like changing their life in a lot of ways, especially people that are first-time testers or people that didn't realize that this was happening in their community. And there's not a lot happening in Vancouver. There's definitely community action happening, but it's in a very small section of the community that not everyone identifies with. And it's, like we mentioned several times, more like a bedroom community. But we've been able to really recruit people that come in to get tested as volunteers that have really become part of what I feel is a community there. Also, just people realizing that people every day that come into our testing clinic in Portland don't realize that we have testing sites outside of Portland, and they're coming like far drives, long distances to come get tested. One of the reasons why I decided to start adding STI testing was just so that we could help serve people. So we started doing some targeted interviews with people that identified themselves in a screening process as living outside of the county where they're testing, and really letting them know, like, hey, we'll give you a gift card if we can talk to you about this. And what we're finding is there's a lot of folks that are really mobilized around that are really interested in accessing services where they live. And it's almost as if they're like filling a gap, I feel, in trying to create a community in those spaces where there's not a community. So.
I would want to add to that. I know for us at Olympia, one thing we always try and do is tap into leaders of these different sub-communities and trying to bring them in. And once we can do that, then it really helps them sell the messaging to their respective communities wherever they're at, although we're a lot smaller.
Go ahead.
Dave Kern from the Washington State Department of Health. Thanks to each of you for sharing your perspectives. I think it's important for all of us to hear these. My question is for Ronnie and the community health worker program. Is that infectious disease specific, or does it broaden out to include other health conditions, chronic disease?
It is starting out as HIV and sexual health specific, but the plan is that folks will, based on the kind of the needs identified by individual houses of faith, that it will expand to other health issues.
Okay. And what level of
after that.
support do you provide? Is it volunteer driven? And what money does the county put in to support those efforts?
We have, actually have helped to get 2 small grants. So we have provided grant writing support to the coalition that's working on that. So we've gotten 2 small grants to support the project. And we have 3 of our own staff, 4 actually. One staff has been on health leave for about a year. But we have 4 of our own staff people who are actively involved in the project also. CAP also has staff people who are involved in the project and supporting. And actually one of the small grants is part of a larger CAP grant, chat grant, focused on youth and HIV prevention. So there's a lot of support coming from a lot of different places for the project.
So the types and kinds of services that are provided standardized across sites, or is it dependent on what an individual faith community wants for itself?
So for the HIV sexual health services, so everybody's receiving the same amount of training, information, materials, etc., but actually how it rolls out will be individualized based on the culture and values of the individual houses of faith. Yeah.
Hi there, Steve Goudreau from the University of Washington. We had, as you all heard, we had a series of talks in the morning about some of the big science that's happening, about sort of what some of the current trends are, about new potential interventions, pre-exposure prophylaxis, new testing approaches, new ideas, about really thinking about our epidemics locally in terms of global MSM and some of those issues. I just want to hear from you guys, what, if anything, this morning in the setting where you work, did you hear something that was like, oh, that will work great where we are. I can't, I'm so excited to get started. I'm thinking about how we're going to do that. And if there was anything in there where you thought that is never going to work where we are, and just take it.
Well, I actually wasn't here for the morning, but I did hear Dr. Ayala yesterday, and I would love some more information on both of the two studies that you presented yesterday, and thinking about how we might use that information in terms of, predictors of self-care and risk-reducing behavior. So I definitely took something from that yesterday.
There's a component to PrEP that I really like. Part of me thinks it's putting a lot of onus on those who are already positive, and at $10,000 a pop, it's a lot of resources for that particular intervention. And it really does, I think, kind of draw away from the social determinants and the stigma issues, and you're really just focusing on I know it's one tool in the toolbox, but it's an expensive tool. And I sometimes wonder, can that money be spent other places that might numerically have a better effect? And again, in our county, what provider is going to stand up and say, yes, I think this is a great idea, I'm willing to take that on and do it for Snohomish County residents?
I was, so this is something actually I've been interested in for quite a number of years and went through a little bit of a workshop, but it's the community-based participatory action research process, which I think has been used here. Has been used a little bit in the Portland area, more around some chronic disease, small chronic disease projects. But it was a good reminder to me about the importance of that. And so, so that was something that stuck with me, and really trying to look at, so there are all these things available to us right now, but what really is going to work and what is the combination that's going to work? And so really going to the various communities and trying to figure that out a little bit better with that strategy.
One thing that I heard that I'm excited about, but that didn't necessarily get rolled out a lot, was what Dr. Steckler was talking about acute infection. I think a lot of folks really could benefit from having access to a test that has a shortened window period. So there's a lot of people that are sometimes using condoms that are putting themselves at pretty consistent risk, that are taking their test result as this is what my test result is today, as opposed to this is what my test result was sometime in the past after my exposure. So I think that could be something that's really beneficial across Oregon and Washington. And if I'm correct, there's been some findings in Seattle area about a number of cases that are identified from acute infection that is pretty exciting from a research perspective, that it's showing that it's efficacious. So hopefully we'll see that technology soon.
The other thing I was really interested in, I'll just say that Patrick talked about, was the kind of this home-based testing and the use of Skype and other online ways of providing services to people via use of home tests. So.
You have any more? We have two people still, so I didn't see who was up first. So here you go. Roy?
Hello, I'm Ray Harris with Center for Multicultural Health, and I had a question. I think that what I'm seeing, and I've just started about a month ago, but what I've seen from my own personal experience with going into prevention offices is that there's a lot of judgment and hounding on people who come in to get tested to not do what they do. And so what I'm wondering is, how can we, as people who work in those offices, make people who come in feel more comfortable with talking about what they do sexually, who they are, so that they can get the information? Because a lot of the reason why people don't want to come in to get tested anyways is because they are afraid of people in that office, is what they're going to say to them, and then their soapbox stand on, you need to stop doing this. Then also outside, where friends, family, and whoever else, if they were to find out their status and it did come up to be positive, they have nobody to talk to. So how can we go about making people feel comfortable, more comfortable on coming in to find out what's going on inside of them?
Well, I have a question back to you about that. So do you think that people would prefer to come in and just get their test and not talk to someone? Because that's kind of the direction that we're moving in.
I think it may be both ways, but I think for the most part, people kind of don't really feel comfortable with talking. I've been doing a lot of looking online as far as how comfortable people feel when they go into offices. And I've run across several times where people just don't feel comfortable. And I just went to a party on Saturday where there's a guy, he's on the DL, and he went into an office to go get tested. And he admitted to me that he lied throughout the test. And I asked him, why did you lie? And he said, I felt embarrassed. And I said, but you're going to go get tested. Why would you feel embarrassed? And he said, well, the people who were asking me questions, I didn't feel comfortable with admitting to them. And so I think part of the problem would be is that people just don't feel comfortable. This is the place you're supposed to go to get the information and find out what's going on. But how can you do that when you don't even fully feel comfortable with who you're supposed to be talking to and who's supposed to be providing you the information and options? And so that's, I think, outside of having all these resources and accessibility and all of that, it does nothing when people don't feel comfortable. And so that's what I'm trying to figure out, is how can we make people feel more comfortable going in rather than not knowing who's there, not feeling okay to talk, because then you're not getting the full story or the full background on that person because they're not telling you the truth completely. They don't feel comfortable.
Right. Well, I think, one of the strategies actually that your agency, CMCH, has used that I don't know, I guess Austin would have to talk about how effective it's been, but, sort of bundling services and not holding out that HIV-specific or STI-specific service, which may feel really stigmatized to people. Certainly the push toward routine testing should also, lower that level, but I'm also sort of concerned that people feel judged when they come into testing, and so that's good to know for us. And I would encourage people, if they hear that, that they express that to whichever agency is providing that counseling and testing, because counseling's not supposed to be judgmental.
Mm-hmm. So part of my experience in working in public health was also implementing social networking strategy intervention, which I found to be, at the time, burdensome and not very effective for the work that I was doing, but with the exception of using that really now. Whenever I have one of those experiences where someone shares a piece of information, usually what happens is they're coming in for testing and they are really uptight and they're really nervous, and then as they move through the testing experience and realize that I'm not going to read the list of questions off of the form, or I'm not going to judge them, and they end up loosening up and letting go, and then they end up sharing that information. Well, I had this bad experience that kept me from testing for the last 2 years, or something of that nature. I really like to use some of the elements for social networking strategy to let that person know that that's something that's changed a lot about public health, or that's something that's changed a lot about this agency, or I'm sorry you had that type of experience, and really getting them to be folks in their community that can tell other people that I had this positive experience, because that's really the way that we can get more people to break down that barrier. Because public health, the history of public health, there's still people that haven't gotten tested in 10 years, that the last time they got tested, they got asked what the total number of sexual partners they had in their lifetime was, and then the person rolled their eyes whenever they said the number they said. So, we don't know if it was just a bad experience or if it's something that was institutionalized in the way that work used to be done. So without making those assumptions, just kind of moving forward and letting them know that they're the people that can change that for their peers in the community.
We have one more question and then we're going to break for lunch. But one thing that I would like to say is it's a really easy thing. You just have to think, welcome home. You have to think of whatever you're doing as your kitchen table. You have to welcome people home. If they've come through your door, who cares? They've made it. They made it. They made it. And it should be like home. You want it to be like home. And even if they don't get a test that time, even if they just come in and chat, you make it feel like home. And when I used to sit on Saturday nights in Club Z here in Seattle, it was really hard sometimes because you're just waiting, and finally it's 12:30 or something, and you just want to get out in an hour, and all of a sudden that person comes in, and you have to all of a sudden forget what you're doing. It's not a job. It's not a job, and it's not a job. It's your kitchen table, and you got to be a good host. So the last question, Eric, right over there.
Thank you for the segue where you introduced the topic of bathhouses. So I'm more specifically interested in the Portland area because I've done work in the bathhouses here testing, so I'm less interested in the King County side of things at the moment. So I'm wondering what the Portland area's relationship is with sex on premises venues, commercial sex venues, bathhouses, whatever you want to call them. If there is a relationship, what does that look like, and what does that look like for your public health efforts around MSM and HIV?
Yeah, I think Cascade's project, we've gone through a number of changes on how we do work in public sex environments in the last couple of years. Working on both sides of the river, because I'm doing some work in Portland. In Washington State, guys hook up at bookstores as well, or they meet people at bookstores, but there's state laws that prohibit people really from or that don't encourage you at least to have sex on premise, versus Portland, which is very much like, cut a hole in the wall and we'll just leave it there, or we'll set up a glory hole maze for you. So it's very encouraging of public sex in a lot of environments, adult bookstores, and we've struggled in the past. And personally, I've made contact with some bookstores in Vancouver that whenever I was working for the health department, were like, absolutely not. You can't be here. We're not going to talk to me. And we've made a lot of inroads in the last couple of years with some of the folks that are here from Cascade AIDS Project to really connect to those bookstores and public sex environments and really let them get them to the point where they're comfortable with us putting up advertisements and flyers to recruit people to testing there. We're not currently doing testing at bookstores, but there's also 2 sex clubs in Portland, and we do testing at both of those. One of them is newer, and Multnomah County Health Department's also doing some testing there. STI testing as well on a pause night that they have, as well as HIV testing on other nights. But it's definitely, it seems to me like there's more options for public sex in Portland or in Oregon than there are for on the Washington State side.
Someone tweet that.
Yeah, I should put that on a billboard or something before you come into the state.
It could increase tourism. I do not work for the Oregon Tourism Bureau.
There you go, the new campaign. We have more options.
Is that good? All right, thank you very much. And please thank our 5 experts.
All right, thank you for